All right, so let's talk about specific conditions besides MI. We pretty much beat AMI to death. So let's talk about a couple of the other ones. Okay? So obviously there can be a pretty good laundry list of problems, whether it's with the vessels. We're going to talk about shock in a couple of weeks with the blood itself. We pretty much just talked about the one when it comes to the pump part of it itself. So coronary artery disease, right, or CAD is how else you will see that. This is what most of us probably know, right? It's a condition that narrows or blocks arteries of the heart. A lot of the reason is this fatty deposit that builds up on the inner walls of the arteries, right? McDonald's, Burger King, Wendy's, Zips. What's that? That's, by the way, I'm hungry. So you get that fatty deposit that builds up, and then what happens is that vessel becomes narrow, right? And then if you have a clot that comes along that may have normally passed through that, it can't pass because that pipe is too small. That clot sticks, and then it's going to cause damage down the road, right? So this is what it looks like, right? This is that plaque buildup in the artery that causes decreased blood flow. Now, before the clot gets there, okay, you can see how this would put pressure on your heart, right? Because if this down here downstream is not getting enough blood, then your heart wants to pump harder to do that, right? So it raises its blood pressure, and if it's always like this, it's going to always have high blood pressure. So your blood pressure is normally high, and then, of course, we know the risk factors of high blood pressure then comes MIs and strokes and aneurysms and things along those lines, okay? So as this plaque gets closer and closer together, you start having damage that's done downstream, right? The tissue starts to die. You start getting chest pain. You go to the hospital. We might call it an MI. We might give you nitro and aspirin and so on. Then they're going to go in and do what's called a stent, right? So they take a wire. They enter your femoral artery, okay? And they run this guide wire with some dye up inside and get down to where the problem is, okay? When they inject dye, they can look at an ultrasound and actually see where in the heart that blockage is. Then they run this guide wire up inside there, and around this wire is basically, or around the wire is a little itty bitty wire cage that has a balloon on the inside of it, okay? They put that in between here and inflate the balloon with a syringe, so the balloon inflates. And then when you deflate the balloon, it leaves that wire cage inside the artery, which basically just broke that plaque and made yourself a bigger pipe. Okay? That's a stent. Okay? It looks like a really, really small Chinese finger trap, right? Like a perfectly woven little metal cage. Okay? That's what gets left there. You hear people all the time with 3 and 4 and 5 and 6 and 7 and 8 and 9 stents in their heart.
And you're like, bro, you just salad.
Yeah. They do, but then it's got a bucket of ranch on it, and it defeats the purpose, right? So in the EMS world, you'll hear us use terms like door to balloon time, right? What we're talking about is the time we walk into the ER to the time that balloon has been inflated, we want it as short as possible, right? Right now, as of last year, one of our paramedics got an award for the fastest response time, fastest on-scene time, fastest delivery time to the ER, and fastest door-to-balloon time when it came to the emergency department, right? We were on scene within 5, which was quickly. We were on scene within 5. We were on scene less than 10. It took us 25 minutes to get from our scene to the hospital. And when we left the scene, he called the hospital and said, this person's having an MI. We want a CAF team ready to go when we get there, right? 25-minute window, plenty of time to get a CAF team. We pulled up to the ER, and there was an entire stent team ready for us at the door. They wheeled us into the hospital, right, into the room. They took him from our stretcher onto the bed that went into the cath lab. It was 6 minutes from the time we walked in the door till the balloon was inflated in his artery. 6 minutes, that's it. Boom, that quick. The only way that happens is you activate this stuff 20 minutes away. If you wait till 5 minutes away from the hospital, like, oh, by the way, this is a cardiac activation, you're going to delay that by minutes, right? We had good 12 leads. We had good diagnostic stuff. Everything just like fell perfectly into place. and it was super slick, right? It was impressive. Before we even left, the doctor's like, hey, we already got a balloon inflated. We already got perfusion back to the heart. We're like, we just wiped down our stretcher. Like, we haven't done it. How did you? And he was like, the way it's supposed to work, just never does, right? Because we don't diagnose it correctly. We don't notify the hospital, whatever the case might be, right? That's what you're trying to get your patient is notify the hospital ahead of time. Same thing for trauma. Instead of notifying the hospital 5 minutes away you have a massive trauma, do it at 30 minutes. So they've got all their trauma resources in the ER waiting for you, right? That's the way the whole process should work. So two terms that get used that people get confused, thrombus and embolism, okay? Thrombus is an occlusion of blood flow caused by a clot that is not moving, okay? Thrombus is something it's something like this, right? This would be a thrombus. Make sense? It's stationary. It's not moving. If this breaks loose and goes downstream, it becomes an embolism, okay? So thrombus is a clot or plaque that builds up that's stationary, and then once it breaks loose, it becomes an embolism. Make sense? Embolism or emboli can move to occlude flow of bloodstream in a smaller artery. It's like your DVT, right? That's a deep vein thrombosis, or thrombus that then breaks loose, gets stuck in your lung that causes a pulmonary embolism, right? Because it was something that had been moving. Does that make sense? Don't ever confuse those two, because you'll see test questions on thrombus versus embolism. Coronary artery disease, still, we talked about chest pain as the most common symptom of reduced blood supply, right? That's nothing out of the ordinary. We've already talked about that. So we've talked about the MI side, okay? Now this is the aneurysm side, okay? A weakened section of your artery balloons and dilates, right? I got two really good pictures here in just a second. So the dilation or the balloon of that, right, this can be treated. This doesn't kill you, okay? When it ruptures, that kills you, okay? This is a really dramatic, drastic picture of like Mount St. Helens as an artery, right? This is fine. You're toast, okay? This is where your aorta goes when it leaves your heart, okay? So it's this nice giant garden hose that runs from the top of your heart all the way down to just below your belly button. Okay? At your belly button, it splits and becomes the femorals eventually, right? Becomes the common iliac artery. See how it looks like it goes through your pelvis or in front of your pelvis. So you can see how pelvic fractures can cause some pretty massive bleeding, right? Then it travels down and becomes your femoral, which turns into your popliteal, which becomes in your dorsalis, right? So if you had an aneurysm dead center, you should anticipate unequal or lacking CMS, right? Now, if you had an aneurysm on one side, then you would have CMS on one side and not CMS on the other, okay? Utilize CMS to rule out or possibly diagnose a AAA, okay? Only if it was up here in the main one, right? If this was damaged, then you wouldn't get any blood flow down here. You won't usually get them like one on both of these. Does that make sense? So this is what an aortic aneurysm would look like, okay? Now you can see what are your signs and symptoms of this that should put AAA on your list, as in like number one. Say again? So there's upper abdominal pain. What about that pain? Ripping, shearing, or tearing. The three words you do not want to hear. Okay? We transported a lady that was complaining of some foot pain. We got her in the ambulance. She had some weird blood pressures, and they're like, that's weird. We get her about 15 minutes from the hospital. She goes into cardiac arrest, so we start CPR, give her a bunch of fluid. We get her to the ER with blood pressures and pulses, right? So we're like, we're going to get a save out of this. Doctor goes in and wants to find out what's wrong, so he injects cardiac dye into the artery. As the dye crosses through the heart and goes over the aortic arch, she ruptures from the top of her aortic arch clear to the bifurcation in her belly button, the entire artery, top to bottom, ripped in half. Right? And the doctor was like, well, time of death is whatever time. The dye was all the pressure, that much dye in the vessel, all the pressure it needed to rupture the entire thing. Right? The entire, literally from right there to right there, unzipped. Right? Tearing, shearing, and ripping. Right? It can be in the abdomen. It could be in the back. Right? It could be high in the chest. It could be down in the belly button. Okay? What other sign or symptom that's unique to this case, this problem only, that you might find? What else? You usually can't. Good question, though. You're on the right track, though. So you would have pain with palpation. What else about palpation? Look at that picture. Yeah, it's a pulsating mass in their stomach, right? The softball will have a pulse to it. So you'll palpate it, and there'll be a mass, and you stick your hand on it, and it'll be pulsating. Okay? That's bad news. The reason why they tell you about pulsating is a hernia will feel the same as a mass, but it won't have a pulse because it's an intestine, not this. That's what we're talking about, a pulsating mass. That's the big red flag. So pulsating mass on one side is a red flag. Ripping, tearing, shearing, that kind of thing, either back or abdominal, is your other big red flag. Make sense? So here's the electrical malfunctions are. That's pretty much the plumbing side. Okay? Now let's talk about the electrical side. So there's a couple of dysrhythmias that you're going to encounter. Bradycardia means what? Slow, less than 60. Tachycardia means over 100. Okay? And then you've got rhythms that don't even produce a pulse. Okay? We always talk about the goods, the bads, and the uglies. Okay? The goods are the bradycardias, the tachycardias, and the normals. Okay? The bads is the over 150, less than 40, and then the uglies are asystole, VFib, VTach, and so on. Okay? We're going to talk about those. We've talked about angina. We've talked about AMIs. We're going to talk a little about CHF. Okay? Talk about angina. AMIs, death of a portion of the myocardium due to lack of oxygen, right? It's a heart attack. Almost always, coronary artery disease is your underlying problem or reason why they're having death of tissue. Okay? Coronary arteries is the underlying cause of AMIs. No, that's fine. So what are your risk factors for coronary artery disease? Someone tell me. What's that? So there's one. So there's number two, so obesity. High cholesterol is another one. High blood pressure is another one. Genetics is another one. So what question would you ask them? Correct. Family history of MIs. Okay, what else? Stress, not as much of a risk factor, but it's a good one to know. Say again? Okay, so we're kind of talking poor diet, high blood pressure, we're kind of taking care of that. What about being a male? Yep. Over the age of what? 45. Males over 45, females over 55. You get 10 years more than we do. Right? Those are your risk factors. So let's say the guy's having chest pain, but the EKG says no MI. But he's a smoker. He's got poor diet. He's got high cholesterol. He's got hypertension. He's a 50-year-old man. All the men in his side of the family have all died from MIs. Are you still going to treat him for MI? Yeah, I don't care what the EKG says. Right? You're getting nitro and you're getting aspirin, and we're taking you to the hospital. Make sense? Utilize, that's the stuff that differential diagnosis gives you, right? Ask those questions. Now you know the risk factors, so utilize those to your advantage. Okay? So these are warning signs comparing men and women side by side. Okay? A little bit different. Females pretty commonly do not use terms like chest pain. Okay? They describe it as discomfort or pressure. Okay? Leading up to it, they start feeling pretty fatigued for several days. Okay? Anxiety, sleep disturbances, back, neck, arm, jaw pain, nausea, vomiting, shortness of breath. Males, or pansies, right? We complain of pain. We break out in sweat. We complain that our stomach hurts. We complain that we can't breathe, right? Because we're clearly dying. This is also what happens when you get a cold. Yeah. Yeah, it's kind of like when you Wikipedia something. Well, either you stub your toe or you have cancer. Like, really, it's two options. Makes sense? So women, you got to be a little bit more careful when it comes to the subtle things they're telling you. Pick up on the fact that it still can be an MI. Right? So here's CHF. CHF is the inadequate pumping of the heart. We talked about left side. We talked about right side, correct? Left-sided CHF leads to edema where? Lungs. L for left, L for lungs, not L for love or loser. Okay? Right side leads to pedal edema. Okay? So tell me how CHF and MI, in a lot of cases, are together. How does an MI cause CHF? Tissue dies. So if it's left-sided, right, left ventral, that left coronary artery dies, so your left ventricle won't pump as good. Now you're going to have CHF or pulmonary edema in that left lung. Same thing goes for the right side. You can have those two together. Cassie, go ahead.
So is it like fluid in the lungs that help, or not help, but like contribute to like pneumonia?
It can usually the cardiovascular, the lung side kills you before you get pneumonia. It's usually too lethal, like you don't get the pneumonia, because it's just fluid. It's not a pathogen. Pneumonia is a pathogen you breathe in, right? It's dust. It's something you ate. It's seawater. See what I'm saying? Just blood and fluid doesn't cause that usually that infection. It's a really good question, though. Okay? So here's your signs and symptoms of congestive heart failure. The reason why pulmonary edema is in there is because that's the one that should key you into it. The rest of these all have other associations. Yeah, this is that rails and crackles, right? This is that bubbling in the alveoli. Because if it's coming from the cardiovascular system, it's going to start real low and work its way up in your lungs.
It's always going to be bilateral?
Always. Yep, both lungs. Rails on one side, you might think about something like aspiration of vomit or fluid. And you got to get vomit, not usually, because you'd have to get that way down, and vomit's usually too big to get down in the alveoli. Jordan, go ahead. Yeah, pneumonia is usually one side, where this is usually both sides. Right. That's why pulmonary edema is on there, is because that's kind of the distinguishing factor. Yeah, pneumonia usually has that ronchi or rattle sound because it's stuck to something and it's causing infection, where this is just watery fluid. So you get that bubbles on both sides. So this is the right side, the pedal edema, okay? Late sign, you can get some JVD, okay? Don't wait for JVD to diagnose CHF. Here's Brendan trying to do JVD. I saw you. Hold your breath and really push on your chest. Let me do some JVD. Do some shrugs. No big deal. I like the I don't care shrugs. I don't care. Okay. I used that a lot when I was a kid. I don't care.
I had a guy that had muscle twitches yesterday, and he was doing that.
I don't care.
Twitching.
Yeah.
I'm like,
Great story.
you always tell the guy.
No. So this is just a visual look, right? We already talked about all the symptoms and all the causes and so on. Okay? Now, if you're presented with this patient, I would sure hope that CHF is on your list of possibilities. She's got them all. Right? Yeah. We got pedal edema. We got the desire to sit upright, rapid heart rate. I love this. Low, normal, or high blood pressure. May cough up pink sputum, difficulty breathing or fast breathing, cyanosis, some confusion depending on how far we are with that. Okay? This is one of those ones that's really important to listen to lung sounds sitting up, right? Because if they're laying flat, you're going to hear rales across all fields of lung, right? Because they're laying flat, that fluid rolls up, right? They're sitting up. It allows us to see how full are they. Do you hear rales all the way to the top of their lungs? That's pretty bad CHF. Are you only hearing it halfway up, 3/4 up, 1/4 up? All that stuff's kind of important. Let's talk about CPR, right? Here's what you're not going to get, the required 6-hour American Heart Association CPR class, okay? What you are going to get is the required American Heart Association CPR class the way it should be taught, which is in less than an hour, right? And then we're going to get a chance to do some CPR, okay? So this stuff in red, okay, not only will you see in the NREMT, you will see it on my tests, and this is the stuff that's important when it comes to the American Heart Association. Uh-huh. That's why you're taking notes, to review your notes in like 3 months when you want to go take the NREMT. Oh, yes. Method to my madness. Okay? So there's 5 elements to the AHA chain of survival. I'm not going to say American Heart Association now, and I'm going to say AHA. Okay? So the chain of survival involves immediate recognition and activation, early CPR, rapid defibrillation, effective advanced life support, and integrated post-cardiac arrest care. Okay? So you have nothing to do with number 1. Okay? That's not EMS's job. Right? This is bystanders. Make sense? What's that? What's that? No, they tell you, like on NREMT, they ask you a question of what you're directly involved in. It's not number 1. That's bystanders' jobs. How so? It's your job as an EMT to walk around and wait for someone to go into cardiac arrest.
I'm just saying, like, if they're not told as, like somebody falls, and, like, when we had a call, we were in class, but they had a call, and it was, like, a fall,
Mm-hmm.
and they're like, oh, yeah, he fell, and they didn't really check on him at all, so then we figured out they have no pulse in them.
And I'm on board with you, but the problem is that there's a breakdown in what we teach the public, because the public should have been taught this is a cardiac arrest. Does that make sense? When the American Heart Association thinks of it, there are pushes for the public to know this is CPR and to activate it. Do you see that? Yeah. Boom. No, yeah, right. Number 2 comes early CPR. Okay, we're teaching the public this as well. 3, yes, there's AEDs being put up in lots and lots of places, but hopefully this is where you come in. Okay, good CPR, rapid defibrillation. Okay, how long do you think that your heart is in VFib from the time it stops to the time it's going to work its way to asystole and be unrevivable by electricity? What do you think? Exactly 10 minutes, right? They say 7 to 10. Outside of 10 minutes, the chances of an AED being effective is very, very slim. Okay? That's awesome, right? Because what's the average nationwide response time for the very first EMS rig? 7.5 minutes, which gives you a 3-minute window to get all your equipment, get inside, go A, B's, and C's, start CPR, get an AED on, analyze, and shock, or else it's pointless. Now you understand why CPR save rates in most places are in the teens, right? Because it just doesn't happen. That's why let's put AEDs in all the cop cars. Let's put AEDs in all of the schools. Let's put AEDs in the malls. Let's put them in gyms. Let's put them in Costco. Hell, let's let Costco sell them, right? Like, that's why AEDs are becoming so popular, okay? The Deer Park Golf Course is going to buy a bunch of AEDs and mandatory them mounted to the golf carts, because then people will stop going to cardiac arrest on the golf course, and it takes us 30 minutes to get out there unless we're out there golfing, right? Which happens every once in a while on shift. That's not true. I'm a horrible golfer. We go bowling on shift, so that's real fun. Number 4, effective advanced cardiac life support. Okay. Number 5, integrated post-cardiac arrest care. Okay. How important do you think teamwork is with CPR? Extreme. Right? I've worked really, really good cardiac arrests where our team is like perfect, right? You just leave and you're like, that was epic. I wish we could have got that on film. And then I've been on those cardiac arrests where you leave and you're like, I wish we could have got that on film so I could go back and be like, you're a moron. You're an idiot. You don't know what you're doing. What are we all doing, right? I got a really good video here in a little bit that will show you the way CPR is supposed to be done, and then we'll talk about how often it really goes like that, which is not very often. Okay? Early CPR, we want trained CPR trained individuals on scene as fast as possible. Okay? We're also working on training lay people how to do CPR. There's a really cool program here in Spokane run by Kathy St. Amon, and it has a name. I think it's Cardiac Something Spokane. Last year, through different events, through Hoop Fest, through Bloomsday, we had a tent that we were teaching bystanders how to do CPR. Right? You walk by us at Hoop Fest, and I go, hey, want to learn CPR? And you'd be like, I don't have 4 hours. They're like, can you give me 2 minutes? I'll teach you how to do CPR. We trained 17,000 people last year in Spokane how to do hands-only CPR. Right? Epic. I don't care if you can do breaths. I don't care if you work in an AED. I don't care if you know how to check for a pulse. I don't care. They're on the ground, and you tap them. They don't wake up, and it doesn't look like they're breathing. Do chest compressions. Right? We basically got rid of all the stuff of, well, if you chest compression a living person, you'll kill them. No, you won't. You'll break their ribs. You'll crack their sternum. You won't kill them. Right? We're getting rid of all the things that we used to teach people that were scary. Okay? The other new one is let's train our dispatchers how over the phone they can teach people how to do CPR. I had to make a phone call to my buddy Eric, who works over here at Spokane CCC. Today, 6 times in the last 12 hours, they did over-the-phone CPR for people here in Spokane. 6 times. 6 people called today that didn't know CPR. They trained over the phone. Right? If one of those survives, it's worth it. Right? That's what we're working on. More and more people you can teach CPR, the better. Okay? So there's a couple of changes, right? The new 2015 guidelines just came out. You're the very first EMT class that's getting them. One of the changes, now I tell you it's a change because the NREMT will reflect these changes. My tests and your homework will not. Okay? Because my tests were pre-printed. Okay? So if you see a depth question on my test or your homework, the answer is 2 inches. Okay? That's how far down you're pushing. From now on, NREMT, and whenever you're doing it in the field, AHA says it's between 2 inches and 2.5 inches. Okay? Anything more than 2.5 inches, you're causing damage. Makes sense? Anything less than 2 inches, you're not pushing hard enough. Make sense? Allow for full relaxation of the upstroke of compressions. Allow full recoil is what we call that. Okay? If you push down 2.5 inches, how far should you let up? 2.5 inches. Okay? Make sense? Here's the other one. On the test, on my test, on the homework, the compression rate is 100 per minute. For the NREMT, and from now on in the practical application of this, it's 100 to 120. Anybody know the songs that are at least those beats? What's one of them? Staying Alive. What's another one? Another one, Bites the Dust. What's another one? The Imperial March from Star Wars, when Darth Vader walks. I know. If you're going to say one out loud, we recommend Staying Alive, right? Because chanting another Bites the Dust is not usually looked at very professionally. Yeah. Okay, the one that didn't change is you're going to minimize your interruptions of CPR to no more than 10 seconds, which means once you start chest compressions, there is never a time until you quit that you are not doing chest compressions for longer than 10 seconds. If you're going to do a pulse check, less than 10 seconds. You're going to breathe for them, less than 10 seconds. You're going to switch chest compressors, should take you less than 10 seconds. How often should you be switching chest compressors? Every 2 minutes. Okay? One of the positions in high performance or pit crew CPR is a timer who stands there and looks at a friggin' watch and says, we're going to switch in 5 seconds. 4, 3, 2, 1, switch. Okay? We're going to stop and check pulses in 5, 4, 3. You get the point? A timer who just sits there. Okay? We here in Spokane County have taken American Heart Association, taken all the good stuff, and got rid of all AHA stuff besides what's worth it. And we now follow what's called pit crew CPR. Okay? Which is high performance, chest compression based CPR. Okay? It works more than you can imagine, right? Seattle still has the highest save percentage in the entire country because of pit crew CPR. Okay? Spokane is second in the state. Okay? Our medical director hates Seattle and does everything he possibly can to beat Seattle when it comes to save percentages. Right? The one thing we don't have is we don't put ambulances in the parking lot of every single Starbucks, which in Seattle is on every street corner. Therefore, there's 50 ambulances in the city of Seattle. Right? Their response time is like 4.5 minutes. Well, of course they're going to beat us. Right? The other one is they slightly skew their save numbers. They say they have a 60% save rate. So truly, they have a 60% save rate if you collapse in front of a trained medical professional. What they don't count in is they have about a 21 save percentage rate if you die in front of a lay person, right? Spokane, we have a pretty high. If you die in front of a medical professional, you have about a 59 or 58% chance of survival. I think we're at about 11% when it comes to cardiac arrest out of the view of a trained professional. Okay? Pulse Point is probably one of the things that we're seeing that's increasing that time, right? Pulse Point is the app you can put on your phone. It's a CPR, what's the best way to put this? It's an app that notifies you of a lot of other crap, but its intention is if there's a cardiac arrest in a public venue within about 1/8 of a mile of your location, and your phone will alert and say there's a cardiac arrest, and it tells you where the nearest AED is. Yeah, me too. Because you can select the other ones that tell you every single time there's a house fire or a possible house fire or a wildland fire or a possible wildland fire or a medical emergency or a car wreck, and it's super cool for like 4 hours. And then you're like turning stuff off. You're like, I don't want to know anymore. Right? So Pulse Point's nationwide. There are lots of places throughout the country that use it. Spokane so far has had 2 documented saves from Pulse Point. We're the first one in the entire country to do it, right? Deer Park Ambulance's claim to fame is the very first one was our employee who's a mechanic at Perfection Tire, right? Has it on his phone alerts, he just happens to look at it and sees there's a cardiac arrest a block up from Perfection Tire on 3rd. Runs up there, right, dumps his tools, runs up the road. As he walks up to I think it was a gymnastics place of some sort, a lady walks out with a baby and says, he's not breathing. Jeff does rescue breaths and 1 round of chest compressions, gets pulses back, and the kid breathing before the ambulance walked up. Right? That's how it works. That easy. Then it happened at the Shania Twain concert, right? Shania Twain concert, someone went into cardiac arrest. There were off-duty firefighters there for the concert that were notified that were doing chest compressions before the medical team could get there that was stationed at the arena. Free tickets to firefighters for appreciation. That's why you support the firefighters, right? Because clearly they don't make enough money as it is. Just kidding. Settle down, Mahaffey. in 2 months. I'm going to find a way to get my cup back. I hate seeing it on your desk. It really bothers me. Makes me want to punch you in the face, actually. All right, so high performance CPR, cardiac output's the key, right? When you're doing chest compressions, what are the 2 things that it's perfusing? Oxygen and blood? No. What are the 2 things it's perfusing? Your brain and your heart. What dies faster without oxygen? Your brain. Right? When you push down, it's pushing blood to your brain, and when you let up, it's pulling blood out of your brain. So it's doing the exact same gas exchange, just as if your heart was beating all on its own. Okay? The sooner the defibrillator arrives, the more likely the patient will survive. Shocking. That's not, like, self-explanatory at all. Yeah, no kidding. We talked about that. So integrated post-cardiac arrest care. So here are the things that you're going to do if someone gets what's called ROSC. Write that term down. R-O-S-C. R-O-S-C. You'll hear us call it ROSC. It stands for return of spontaneous circulation. Okay? This is that moment where you feel like a badass. Right? You're doing chest compressions. If you're lucky, they open their eyes, stand up, and say, "Thank you very much." Right? I'm waiting for that one. Okay? Normally, they just get a pulse back. They're still not, the eyes are still closed. They're really not breathing real good on their own. Still feel like a badass.
Most people get tubed, don't they? So if they open their eyes and see something like,
I see push-ups in your future today. Stop. Let's not go there. Okay? So here's the things you're going to do with ROSC. Number one, I want you to maximize adequate oxygenation. Okay? If you haven't hooked your BVM up to 15 liters, now's a good time. Okay? What does number 2 say? Avoid hyperventilation. How do you do that? Count like you're supposed to, 1 every 6 seconds. This is this very, very delicate time. If you hyperventilate after ROSC, you have a chance of killing brain cells that will keep them from coming off a ventilator and ever walking out of a hospital. Okay? So, count. 1, 2, 3, 4, 5, 6, bag. 1, 2, 3, you get my point? Do not hyperventilate them. Yeah, that's a little fast. Yes, sir. So, perform a 12 lead if you're allowed to, okay? I'm going to tell you the H's and T's here in a second, okay? The H's and T's are the treatable causes of cardiac arrest, okay? Then you're going to find out where they're going to go, whatever's appropriate, okay? Sometimes it's the nearest facility. Sometimes it's a specialized facility. If you do a 12 lead and find out they had an MI, they need to go to Sacred Heart. All of our cardiacs here in Spokane go to Sacred Heart, every single one of them. That means you go past a hospital to get to Sacred Heart. Even if the systems are real busy, and you'll hear terms like divert, right? Systems are real busy, Sacred Heart's overloaded, Deaconess is overloaded, and they go on divert, which means they're no longer accepting ambulance traffic. Sacred Heart cannot deny pediatrics, traumas, and cardiacs. Okay? They have to take them, busy or not. We take them to a different hospital. What do you mean? Yeah, that's the reason why they can't deny them. Yep. Yeah. Deaconess, I don't think Deaconess can deny strokes, because technically Deaconess is our stroke center. They're level 1 stroke center. Go ahead.
how many patients deny that the hospital could go and never die there?
All the time.
Do you take them there anyway?
No, we try to avoid it if we can, right? What'll happen is they'll be like, I cannot go to Holy Family because I don't like it. And you're like, well, bad news. We're sorry to tell you, but Deaconess is on divert, Sacred Heart's on divert, Valley's on divert. And I've had patients who be like, fine, I'm not going, give me a refusal. Like, I mean, sometimes that's literally, they're like, nope. Then that's a life-threatening, we're convincing them to go. Like, they're going to go. Yep. Yeah, if they're like, well, I don't like to go to Sacred Heart because people die at Sacred Heart. You're right, because they're the most critical hospital in Spokane. So therefore, the most critical patients go there, which means there's probably a good chance they're going to die. Right? But no, you really should go to Sacred Heart. Right? The nice thing is we now have this freestanding ER on the north side of Spokane. Right? Positive or negative, oh, it's roaring. Positive or negative, that allows us another hospital to put patients in.
How many beds does it have? I heard it was like somewhere in 15-ish.
It's quite a few. They're pretty substantial standalone ER. we had a whole new set of protocols that just came out that I haven't even looked at yet about what can and can't go there, right? A cardiac, a trauma. I know it's like a pediatric less than a certain age with a certain temperature can't go there, because you're trying not to generate 2 bills or 4 bills in that case, right? Deer Park ambulance to standalone ER is 2 bills. If you know they're going to get admitted, now they get an AMR bill and then another hospital bill because they're going to be moved to a hospital. So it might be better just to go past that standalone ER and run to Deaconess or Sacred Heart or wherever. Okay? Possibly inducing hyperthermia. If your protocols allow, you can introduce hypothermia to those cardiac arrest patients, right, after they have a pulse back. Why do we purposefully lower their body temperature in return to spontaneous circulation only? What's that? Other way around, actually. It actually does what to their heart rate? Drops it. So you lower the stress of the heart. What else? So you try to take out the rest of the body. What else? It slows your metabolism. In change, what does that do? Uses less oxygen, right? One of the miracle cases, they had a 12-year-old kid that fell in a lake in North Dakota, was trapped under the ice, okay, for 72 minutes. They pulled him out of the water, resuscitated him with 0 deficits, okay? Hypothermia, basically, if you think about all the oxygen you're building storage right now, if you drop your heart rate to 30 and your blood pressure to 60, then if you're in hypothermia, you use your reserves slower, right? So your body doesn't need oxygen as fast because you basically load everything to a crawl. That's exactly what we're doing, right? The one save I had, we introduced hypothermia in the field. The hospital put him in hypothermia for 48 hours, right? I guarantee you that component allowed our guy to leave with 0 deficits because he had a downtime of 42 minutes. That's start to finish. From the time CPR started to the time we got pulses back was 42 minutes. We shocked him 6 times, right? We thought for sure he was going to be brain dead. I guarantee hypothermia fixed that. God bless you. Make sense? So if your protocols allow you, do it.
How do you introduce hypothermia?
So cold packs in the armpit, the groins, and behind their neck, right? Hospital gets a little more aggressive of a blanket that actually cools them. What are you asking, sorry? Yeah, your core area, the best place you can get to a core, you dump their body temps. The body temp you're looking for is about 92 degrees Fahrenheit, right? It's pretty damn cold, okay? We don't have the ability to control that. We just start getting them lowered, and in the hospital, well, then we're about controlling that and stabilizing that. So here's your 6 H's and T's. Now, there's some big words up there, right? So write them down, and then I'll talk about the definitions. Hyperkalemia, hypoxia, hypothermia, hydrogen ion acidosis, hypovolemia, hypoglycemia. Those are your H's. Okay, T's, tamponade, we're talking about cardiac, tension pneumothorax, thrombosis, we're talking about pulmonary embolisms or MIs. Those 2 you can put just as 1. Toxins and trauma. And then a really good flashcard of, I would write 6 H's on one side or 6 T's on one side and go like that. Okay, so hyperkalemia, who wants to take a crack at it? You know it's high, right, because it's hyper. Take a guess at kalemia. Anyone want to take a guess? Potassium. Derek, did you know it? Yeah. Say it, man. Come on. You want to take a crack at hypoxia and make me feel better? No? Fine, you can tell me to shut up. I don't care. I've never picked on you. Not yet. Hypoxia, low oxygen, right? Hypothermia, we just talked about, right? During cardiac arrest, you want them warm, okay? Hydrogen ion acidosis, we're talking about low pH, which is high acid, right? Hypovolemia, which is what? Low blood volume, right? Hypoglycemia would be low blood sugar. On there, the most common reason for continuous cardiac arrest is hypovolemia, which is why we start IVs on so many of our cardiac arrest patients. That gives access for drugs. Make sense? On the T side, tamponade, we talked about cardiac tamponade, right? This is that squeezing of the heart. Tension pneumothorax, we talked about. It's just a really, really bad pneumothorax. We'll talk about it more with trauma. We got a pulmonary embolism or an MI. Toxins, one of the reasons why we give Narcan to our cardiac arrest patients. And then trauma, traumatic causes. Okay? When you work with paramedics and we got this cardiac arrest that's still going, right? Before we call it, we list our H's and T's. We're like, all right, so let's think about correctable causes. Are they hyperkalemic? So we'll give sodium bicarb, or I'm sorry, we'll give IV solution or I think it's calcium gluconate, maybe. I can't think of it for sure. Hypoxia, are their SATs 94 to 96%? Okay? Hypothermia, what's their body temp? Hydrogen ion, let's give them some sodium bicarb to see if we can lower their acid. Okay? Hypovolemia, let's make sure we got a line started, if not 2 lines, and let's give a liter of fluid as a fluid challenge or a fluid bolus. Make sense? Hypoglycemia, let's check their glucose. Then we go on this side. Cardiac tamponade, we got JVD. Nope. Okay. Tension pneumothorax, we got equal and clear bilateral lung sounds. Thrombosis, are we worried about a pulmonary embolism? Do we have any of the risk factors? Are we worried about an MI? Do we have any of the risk factors? Are we worried about toxins? Let's give them some Narcan. Do we got any signs of trauma? The answer is no, then we've got all the things that we can treat in the field when it comes to 6 H's and 6 T's. It's not uncommon for paramedics to dart the chest to just make sure there's no tension pneumothorax. Take a needle, puncture the chest cavity, and make sure that's not the problem. Okay? With trauma, it's really, really common. Medical, every once in a while, you'll see it done. Okay? The 2 links that we hold as EMTs, early CPR, rapid defibrillation. Make sense? Pretty sure there's 1 or 2 test questions on your next test related to that right there. That's why it's in red. Good. All right, so how do you choose between 1 or 2 rescue or CPR? What do you think? How many people you got? If there's 2 of you, probably going to do 1 person CPR. Right? If there's 6 of you, let's go with 2 rescue or CPR. Okay? What BSI do you need in cardiac arrest? Gloves and eyewear. Right? If you're in the airway position, I'd really encourage a mask. Okay? It's going to get ugly. Request ALS, clearly. Use a BVM. It's not shocking, right? Emergency move these patients. Okay? Lift and move them to get into a place that you can do your job. Okay? What do you think is the first airway that's used in almost all your cardiac arrests? OPAs. What is the best airway an advanced EMT can use? King airs. What's the most definitive airway? ET tube. Okay? What are bystanders and families going to tell you? What were they doing before? What else? Medical history, allergies, medications. They complain of something. Don't forget to interview bystanders. Make sense? What's that? What they ate? Okay, I like that. 2 types of AEDs. There's semi-automatic, and there's fully automatic. Okay? Notice that fully automatic does not advise the EMT to take any action and to deliver shock automatically. How many of those do you think you still see? Not. Hopefully, because you have less EMTs. Okay? Semi-automatic advises the EMT to push a button, that allows them to then shock. Okay? We're going to talk about making sure people are clear here in a minute.
Definitely kneel over the arm.
Yeah, definitely. Definitely shock while there's an AMR paramedic still touching the patient. Classified, there's two types of shock. There's monophasic and biphasic. Monophasic sends a single shock from a negative pad to a positive pad. Okay? A biphasic sends shock in one direction and in the other. Which one do you think is better? Biphasic. Which one of these do you think takes less electricity? The biphasic, right? Monophasics normally shock at 360 joules. Okay? Biphasics normally shock at about 200 joules. Make sense? Because it's going one direction and then back, you don't have to use as much electricity. It's a little more accurate. Please. So, common misconception. Your AED will only shock two rhythms. Shocks VFib and shocks VTAC. Okay, VFib stands for ventricular fibrillation. VTAC stands for ventricular tachycardia. Okay, does your AED or any AED or any level of care in the entire world shock asystole? No. Every single movie or TV show you've ever seen that shocks flatline is 185% false. You cannot shock nothing. Right? How many times have you seen them shock on Grey's Anatomy asystole? 5 an episode. Right? You can't. Yeah, you can't. It's impossible. There's no you can do it all you want. It's not going to do any good. What do you want? That's what we're going to talk about here in a second. It's notes for me, right? What movie was that?
Flatliners?
Oh, great movie. Yeah.
But not realistic.
It's pretty realistic. A bunch of doctor students hanging around, purposely putting themselves in cardiac arrest, and then their bad dreams come back and try to kill them. Totally accurate. Yeah. 100%. That's the only downfall. That's the only downfall of Lone Survivor, right? Opening scene, they're shocking asystole of him in the helicopter, and I was like, that's it, I quit. Right? This movie sucks. It rapidly got over that, let me tell you. Okay? So, ventricular fibrillation, does this ever produce a pulse? 50-50 chance. Take one. No. Congrats, you won. Right? Yeah. It can't. Yeah. Oh. That's right here, man. I can feel that all in my, I think it's tearing, in fact. Ventricular tachycardia. Can it produce a pulse? Yes. Yes. Does your AED know the difference between VTAC with a pulse and VTAC without a pulse? It doesn't. It just shocks it. This is the reason why you never put an AED on a patient with a pulse. Because there is a ventricular tachycardia is a fast heart rate caused by your ventricles. Okay? We're talking a heart rate of about anywhere between 100 and 150. Okay? But it's just your ventricles firing. Now, it's not doing a very good job of perfusing, and if you stay in VTAC, it will go into VFib. Right? Because your heart rate's it's firing so fast, eventually your heart's like, nah, it doesn't work, and then it just goes into fibrillation. Okay? It doesn't know the difference. Your AEDs will never read whether it has a pulse or not a pulse. It just looks at that rhythm and says shockable or not shockable. Make sense? So this is what VFib looks like on a monitor. Okay? Remember the EKG strip we talked about, right? It had P waves and QRSs and T waves, and it was equal and all that stuff. What do you notice about this? Yeah, it looks like a 3-year-old trying to draw their name. Okay? Totally random. Okay? No consistency. No way to check P waves, QRSs, T waves, nothing. Right? Does this produce a pulse? Never. Okay? What is the only treatment for VFib? Shock it. Okay? That's what VFib looks like. So here in a second, he's going to slide these paddles in here and shock the hell out of it. That's what it should look like. You can hear the irregular heartbeat here in just a second. Double beat right here. And look at all the fatty tissue. We talked about this. It's got a gallon of ranch. That's what normal looks like. Okay? Notice how many joules they used. How come so low? Those pads are touching the heart, right? They don't need 360 of them. Parents calling? You want to take that? We can talk to them if you want. We turn the lights on. It'll be real fun. Hey, Mom. Hey, Dad. This is my class. All right. CPR must be paused for rhythm analysis and defibrillation. Okay? Can you do CPR while it's charging? Yes. Please do. Okay? So chest compressions, AED goes on. Great. Let's analyze. Everyone stops. It says shock advised, start CPR. Okay? It charges, and then it's going to say, push to shock, and it's going to make this really annoying noise. Before you get all excited about your powerful job of 360 joules, make sure nobody is touching the patient. Okay? Including everybody. Okay? If not, there's some damage involved and usually a lot of anger. Right? So, you arrive on scene to a scenario. Bystanders are doing CPR when you arrive. Have them stop. You're going to verify that they're pulseless. Verify their apneic. Make sure there's no other signs of life for no longer than 10 seconds, and then you're going to go back to CPR. Okay? That's how you check a pulse. Before you put on the AED, of course, you have to bare the patient's chest, right? Shocking. You can't put the AED pads on their clothing. Sorry. Okay? If they're hairy, you're going to quickly shave the chest with the razors that are usually in the AED bags. Okay? If there's no razors, here's the not fun part. As long as you have 2 sets of pads, one set of pads go on, and you rub it real good so it sticks, and then you rip them off and put the second set of pads in the giant bleeding, gaping hole you just created. Okay? Just wax the area, no big deal. What's that? Yeah, if they're faking unconscious, you're going to wake them up. Okay. What's that? Yeah, that's the painful response. If someone's sitting at the AED, someone needs to be doing chest compressions. Okay. Do you ever stop chest compressions to attach the AED? No. There's no reason to. Okay. Where do the pads go? One goes right here, and one goes. Damn it, wrong way. On the other side. Right, the left side. Sorry, I was trying to look at the picture. Left side, on the side. Half of you, right there, buddy? Just checking. What's the very first thing you do when you get the AED? Turn it on, then attach the pads, then let it analyze, then clear and shock. Okay, that's a shock button. After you deliver a shock, the only reason that you do not start chest compressions is if they sit up. Okay, that's it. No other reason. Okay, you hit shock, you start chest compression. Right? No pulse check, no breathing, nothing. You immediately start chest compressions. Okay, after 5 cycles of CPR, then you can reassess, is there a pulse? Make sense? Shock, chest compressions, back to back. Okay, one pad goes there, one pad goes there. That was the picture I was looking for. Use the unless the patient wakes up, moves, or begins to breathe. Okay? You're supposed to stop chest compressions after they say ouch twice. Blair, go ahead.
Is there an amount of time that, the max that you can shock an AED, will it stop shocking?
Only if it ever dies. But it'll just keep shocking and shocking if it can until the battery goes dead. If the AED finds no shockable rhythms, the non-shockable rhythms would be what's called PEA, or pulseless electrical activity. It will not shock asystole, and it will not shock NSR, which is normal sinus rhythm, which is normal. Okay? Pulseless electrical activity, what confuses the monitor, this is going to be a really long backtrack, that's right. What confuses the monitor is it looks just like, almost there, looks just like that. Okay? Pulseless electrical activity is, there's no pulse, but the electricity is firing. SA node, AV node, bundle of His, right and left bundle branch, Purkinje fibers. It's firing, it literally looks perfect. It's just, there's no pulse with it. Okay? So, just do chest compressions. Okay? You can't shock it, but you can do chest compressions. Took longer. Okay? Asystole flatline, shocking, we talked about that, and then it won't shock normal, thankfully. If it says no shock advised, start CPR. Compression should never be interrupted longer than 10 seconds. We talked about that. How many times have you seen that? Twice. Depth 2 to 2.5 inches. On an adult, children, it's 1/3 the depth of their chest. Okay? That's about 2 inches. Usually about 1.5 to 2 inches. So you'll see it as 1/3 the depth of chest for infants and children. Okay? One of the things on your NREMT, cardiology or cardiac emergencies, this chapter right here is an entire section of your NREMT exam. Okay? That's why this takes so long. We talked about 100 to 120, right? Rotate personnel, how long? 2 minutes. How often do you, or how do you keep track? A timer. Okay? Patient wakes up, begins to move, congrats. Pull out the airway. Okay? Vital signs, oxygen, think about transport. They're probably going to go to the hospital. Okay? Don't let them refuse. That has happened. Right? District 4 had a guy that was, son committed suicide, or tried to commit suicide. Dad found him. EMS got there. Dad had a massive MI, went into cardiac arrest right in front of his kid. Right? 17-year-old kid that had taken a bunch of pills. So fire department jumps right on it, gets chest compression, shocks him once, and this guy came up off the floor and was yelling, screaming, swinging, whole 9 yards, and adamantly refused to go to the hospital. And they were like, you were just dead 30 seconds ago. He was like, I'm not going, I'm fine. Yeah, okay. Right? Way to use law enforcement to transport him. Because he wasn't going to go. You're like, you were dead, bro.
Did the medic ride with the cop in case he just...
No, the cops, we still go with us. The cops just put him under arrest, based for his own safety, and we transport him. Yeah. Critical?
Well, I know it would be critical, but alter mental status, or he could make that decision.
Yeah, that was our justification, was clearly there's something not all there, right? We also kind of used the fact that his dad died because of the stress his son put on him to tell the son how serious his actions were, right? We're like, yeah, hopefully. We never went back on him, so that's good. Why would you check a pulse during chest compressions? Should they have a pulse while you're doing chest compressions? Yes. So if you're checking for a pulse for the purpose of, does he have a pulse? Make sure no one's doing chest compressions, right? Yep, you're just making sure you're getting, because basically that tells you you're getting blood all the way up to the carotids, which means you're doing a pretty darn good job of getting to the brain. We're going to talk about that stuff in a second. Check the batteries at the beginning of your shift. That's always important. We're going to talk about ALS here in a second. We're going to talk about it. It's all coming up. So patient has a pulse, right? This is post-resuscitation. They get a pulse, but they can't breathe on their own, then bag them, right? If you haven't put a King Air in place yet, now's a good time, okay? It's pretty rare King Airs go in during cardiac arrest unless there's an absolute need to do so, okay? Your OPAs will work just fine. As long as you're getting good chest rise and fall, you're getting good saturations, you're doing all right when it comes to lung sounds, then don't worry about the King Air. It's not a priority, okay? This is the one time you leave the defibrillator on the patient just in case they go back into cardiac arrest. Okay? If they got a pulse back, would you consider them to be critical? Yes. So monitor their vitals every 5 minutes. Okay? One of the new things we're doing here in Spokane is if you get a return of spontaneous circulation, we actually do not transport you until you can stay alive for 10 minutes. Right? Before, you got a pulse back, we'd throw you in a bus, we'd take off for a hospital. 60% of our cardiac arrests would die within a 10-minute period. So now you're transporting a cardiac arrest, right? So you get a return of spontaneous circulation back here in Spokane, everything kind of stops, right? You check a pulse. That person checking a pulse checks a pulse consistently for 10 minutes. So one person's on a pulse check for 10 whole minutes. Yep, you still sit there. You don't move. Okay? So you're holding the pulse for 10 minutes. You get another person who starts a second IV if you haven't already done so. You worry about intubation if you need it and if you haven't done so. And you start thinking about drugs to give, saline, dopamine for blood pressure, stuff like that. And everyone just kind of sits around for 10 minutes, right? Get them ready for transport, get them ready to go. The nice thing about the pulse check, the second you lose the pulse, you're back on chest compressions. You can maintain a pulse and a blood pressure, or a pulse for that matter, for 10 minutes. Great, we're going to transport you. Make sense? Go ahead.
Is it not problematic to hold your hand on?
You're just not pushing real hard, just like nice and light, right? The monitor works good. End-tidal CO2 works. We use all those tools in conjunction.
So is that because you lose, like you can't detect if they lost pulse during transport? Or?
It's just because the chance of them losing a pulse is very high, right? And now the dangers, what we're finding out is even Spokane County protocols, this will tell you here in a second, and I used to be like, well, we don't do that. Well, Spokane County, if you go into cardiac arrest during transport, we pull over and stop. We used to just drive with people standing up in the back of the ambulance and then tell people nationwide, you wreck a bus with us all standing, you kill everybody. So now it's like it's unsafe for you, it's unsafe for the public, it's not worth it. So it's just not worth it. Make sense?
And on top of that, if you have to pull over for some reason and you die,
Well, yeah, then you're
now
you're stuck there. Yeah, until the coroner comes and gets the body. Talked about that. Adequate ventilation. So you're still looking for that 94% of oxygen saturations. What are you looking for on your end-tidal CO2 with chest compressions? 25 to 35. So patient goes back into cardiac arrest, stop the vehicle, resume CPR, right? Have someone else start CPR if the AED is not immediately ready so you can get it, right? Analyze the rhythm, shock if indicated, and then work through your 5 cycles just like before. Make sense? Not a whole lot changes there. Witness arrest in the ambulance. There is a good chance, right? Because you are right there. So hopefully you want chest compressions right away, but AED is pretty high on your priority list. Okay? I'm trying to hustle so we can take a break and we'll do snares after that. So bear with me. Single rescue with an AED. Okay? Apply the AED and defibrillate as soon as possible. Then do chest compressions. Make sense? Pretty easy. Contraindications of AEDs. You cannot defibrillate a soaking wet patient. Okay? I don't know why we have to tell you this. If they're touching metallic objects or other people, don't shock them. Okay? Do not put your AED pads directly over some sort of medication patch. Okay? Take the patch off, wipe the skin clean, and then put on your AED pads.
would nitro ignite?
No, it's basically just there's a barrier between now that electricity and the skin. And that could ignite just from the electricity. That's the only reason. It has nothing to do with, like, they picked on this because it probably just, like, there's morphine patches, fentanyl patches, smoking aid patches, all that stuff. You just don't want something between them and that pad. Make sure someone says real loud, I'm clear, you're clear, everyone clear, clear, push the button. Watch out for paramedics. It's like one of my favorite comics. I was showing Rod over here how I accidentally defibrillated Mike over there. That's funny. Super funny. I wish we still had paddles because that really made you feel like a badass. Can you defibrillate somebody with an implanted pacemaker? Yes. Can you defibrillate someone with an implanted defibrillator? Yes. If it was doing its job, they wouldn't be in cardiac arrest. Okay? You just can't put your pads directly over the device. Okay? The device is in the way. Usually when it's on the right-hand side, just take the pads lower a little bit. Make sense? You can see it because it looks like a small pack of cards underneath the skin.
So if somebody had an internal defibrillator
Mhm.
sitting on like a metal bench with them, and they stop, what happened?
Implanted stuff has no danger to you. Yeah. We'll talk about, because they talk about special needs patients, and we'll talk about those kind of patients. Cardiac pacemakers, no pain to patient, no danger to EMS. Okay? Implanted defibrillators have pain to patient, but no danger to EMS. Pacemakers are small amounts of electricity. Okay? Little shocks to remind your heart to beat. Implanted defibrillators still shock patients at about 100 to 150 joules. Okay? We've seen those malfunction in the conscious and alert patient who gets the 150 mule kick to the chest and calls you and says, my pacemaker or my defibrillator is firing. And you get there, and about every minute, minute and a half, that thing fires. Right? And they're like, oh, God. I really wish I could turn this off for you, but it's fun to watch. Just kidding. And we know what an LVAD is? One of the coolest devices you'll ever see. It's a left ventricular assist device. Okay? It's a fanny pack. I have a picture? I don't. It's a fanny pack that's it's a mechanical left ventricle. Okay? They wear it like a fanny pack or like kind of like an over-the-shoulder sling. The creepiest thing about these people is they don't have pulses. Because the ventricle, it doesn't pulsate. It's just a constant hum of blood. So they have no carotids, no femorals, no radials, no nothing. And they are conscious and alert and talking. It's the creepiest thing you'll ever see. Right? No pulses. Super cool.
If you come across one and they're unconscious, like obviously unconscious.
They tell you to put your hand on the device. If it's humming, it's working. Right? There's even a sticker on it that says, like, in case of emergency, call this number. And they can tech support you through to make sure the device is working. It's got lights, it's got batteries, all kinds of stuff. The nice thing is the companies here in Spokane, in the Spokane County area that manufacture these and run these, go notify the ambulance companies if someone moves into your area with them. Right? We just had I think he's 19 years old, moving to Deer Park, and the LVAD company came to us to tell us he was there, how to use it, how to assess him, all that kind of stuff, which is like, thank God. If I walk in, you don't have a pulse, I'm gonna do chest compressions.
So if you did chest compressions on those people and their heart hasn't been beating they've been using this LVAD for,
It's not gonna hurt it.
but is it going to help them to do chest compressions if their heart doesn't work?
Probably not.
You see what I'm thinking?
Yeah, because the rest of your heart still has to be doing its job, right? It's just the left ventricle that's just pushing. So unless blood's getting to the LVAD doesn't push blood out. Does that make sense? So your chest compressions might go through the LVAD, but without it, it's not doing any good.
Why would someone need one of those?
Usually it's when they're waiting for a heart transplant. So their heart's malfunctioned or damaged, and they're on the transplant list, and this is what they use to try to keep them alive long enough to get a heart transplant.
Did the company say it's more beneficial in an unconscious patient to do tech support for the machine?
They tell you, yeah, if you go on it and it's a cardiac problem, that you call the tech support. Because they talk you through if it's malfunctioning, what lights are, the machine can tell you problems, all kinds of stuff. Yeah. We'll talk about quality improvement maintenance stuff later. We'll talk about all pulses too. Terminating rescue, right? You as EMTs can only terminate resuscitation when you turn this over to a care provider higher than your level of training, like a paramedic. Okay? If you are absolutely too exhausted to continue, like if you were doing this all by yourself, you can stop. Okay? A physician tells you there's a no resuscitation order in place. That's pretty much it.
What if you don't have a paramedic or hire?
You transport them to get to someone who can tell you can stop.
But can you call medical control and?
No, because they still have to confirm asystole. And if you have an AED, you can't confirm that. Make sense? You transport them. On the monitors, absolutely. But if you're only using an AED, you can't see them. Heart monitors will show you what asystole looks like. LifePak, Zols, all those. So this is what a good cardiac arrest looks like. I'm waiting to have one of these. It's my goal in my EMS career. Of course, this is staged. Shocking. This device is a feedback device that tells you if you're pushing hard enough or not. And then didn't come back and try to help him. He's not very liked in the office. So these are paramedics, the guys in the white, like angels. You know why firefighters spray water on car accidents? Someone for the paramedics to walk. So notice how nothing stops, right? IVs, you'll see intubations. Chest compression's still just going, right? Don't stop chest compressions for these maneuvers. I know you're not doing IVs and stuff like that, but there's no reason for this stuff to stop. So that's your end-tidal CO2. Makes sense? See how nice and cool and collected that is? So what are the things you think that they're writing down? You saw the guy at the clipboard, right? What do you think's getting written down? So time they started CPR, when they shocked,
The times when they push drugs.
so times when they pushed drugs. You're on a roll. Keep going. What? So they're going to write down dosages with those times, when IV was placed, when vitals were taken, anything that was done, right? When you shocked, was it a shock advised or a no shock advised? When did you start CPR? When did you drop the OPA? When did you drop the NPA? When did you drop, or when did you do the BVM? When did you hook up oxygen? What drug was given? How much was given? All that stuff has to be verbalized so it can be written down. Make sense? That's the importance of documentation. One of the things you're going to practice today. Any questions on any of that stuff? Go ahead, sir.
How does an IV interact with when you're shocked? Is it just a...
You just don't be hanging on the bag. Just set the bag down. Really, the only dangers is between those two pads, right? It doesn't really affect the limbs of the rest unless they're touching something metallic that's then touching something else. Let go of the bag. You're supposed to detach it and turn the bag away because the bag's blowing pure oxygen. If you're blowing that at the AED pads, there's a chance of it igniting, right? And then it's a lot of paperwork. You light your patient on fire. No. In fact, it just happened in the Spokane County area where a firefighter pushed the shock button while there was an AMR medic touching the patient. There was no transfer. There was just a lot of anger between the stupidity of shocking while someone is touching. It can happen. I've just never seen it happen. Keep going.
How serious is, like, rain? You know what I mean? Like,
Just not soaking wet.
emergency move people out.
No, just not soaking wet. Take them out of the water, wipe them real quick, and then that's it. Yep. Yeah, try to give yourself some sort of, like, a cover, but nope, you're going to shock them. Just don't be sitting in a puddle, hopefully. Yeah. All right, take a quick